It was an amazing lecture, and it's very nice to do it this way in a relaxed atmosphere because there's no time pressure. One question is about the pathogenesis that we discussed of chronic intermittent hypoxia and the timing. Obviously, we discussed many factors. In the first 2 weeks, it's less because the baby is on more support. Probably the fetal hemoglobin is high, and majority of these babies need transfusion after that period. But we also have progressing feeds in these babies, and we discussed recently about what do we do with respiratory support in babies on significant progressing feeds, because these are small babies. Say we are only talking of the extreme preterms, less than 1 kilo babies, and when their stomach is distending, it's going to affect their respiratory physiology because the diaphragm is going up. And what happens with the brief episodes of breath holding or the apnea or whatever we call it? I mean, the functional residual capacity is going to drop more. Is a baby going to recover on their own, or is it going to need more support? And that's why when we spoke recently in our unit about weaning the pressure, I mean, you gave a pattern of continuing CPAP longer. We tend to come off the CPAP at the earliest possible that the baby would tolerate because of the nasal trauma mainly. We are using the high flow once a baby is on less than 0.3, I fully agree, but we don't put a gestation cutoff for that. We move to high flow when they are like stable on CPAP of 4 to 5 centimeters and their gases are stable. FiO2 below 30%, then we move to high flow as a trial, or we give the CPAP with a high flow interface to start with, or a ram cannula. And then if they tolerate it, we continue to wean because it's a bigger benefit for the baby if they can tolerate it. And of course, we don't hesitate to escalate them back to the CPAP or NIPPV if they don't tolerate. So the question of when to wean the high flow came up, and the point I was making is that in a very small baby where their ability to recruit their lung is limited because of their size and due to other factors, we shouldn't wean the pressure below a certain level, say 3 to 4 liters on high flow till they are bigger than 1 kilo, for example. So not to rush weaning the pressure fully off, but that small amount of pressure might help to keep the functional residual capacity and might reduce these intermittent episodes. Similarly, what Abu was said about keeping 23 to 25% oxygen. As you rightly said, the hyperoxia is not going to go beyond a certain level because the PaO2 is linked to your saturation. So if you give 23, 25%, the episode of hypoxia may reduce. At the same time, we may be able to keep them without going much into the desaturation episodes. So the question, these are more comments than questions, but the question is basically the histogram. I mean, the cutoff points, I mean, how defined are they? And I mean, do you think we should go for it based on your experience? Or I feel it's safer to wait rather than getting into medico-legal problems. What do you think?
Yes. So I don't, the issue about, there are a few questions. One is the medico-legal, second, or you recommend about when to stop CPAP, go to high flow nasal cannula. So let's talk about first CPAP to high flow nasal cannula. Different patients are different. I have a baby myself that was on CPAP and very distended abdomen, and we had difficulty in feeding that baby. And as you know, the CPAP belly syndrome. So that baby, I wanted by all means, if I could go from off CPAP as soon as I can. So we went earlier to high flow nasal cannula, but no one says that high flow nasal cannula distends less the stomach than CPAP. CPAP, as we use it, it uses the Bernoulli system where the flow switches direction during inspiration toward baby, during expiration back out of baby, while the high flow nasal cannula does not have the Bernoulli system. And I don't know how much high flow nasal cannula, I don't know your comment or your experience, Dr. Dua and the whole team. Does high flow nasal cannula cause less distended abdomen than CPAP when used in a correct way where you keep 50% of the nostrils open? So I'm not sure that we gain into the feeding by going to high flow nasal cannula. That's the first question, first point. Second point, you know, yes, randomized control trial showed clearly that initial treatment with high flow nasal cannula produce half less benefit than CPAP. But when they went to CPAP for versus high flow nasal cannula, they didn't find a difference. Yes, in numbers, but it doesn't seem logic to me if a 25-weeker was needing so much the CPAP on day 1, day 2 of life, and because we extubate quickly on day 2 of life or so, to CPAP, then we say, okay, no, go to high flow nasal cannula because the literature said so. Because high flow nasal CPAP, it's shown that prevents RDS of prematurity, not only treated. So I would like to extend as much as possible high flow nasal cannula. We might, not everyone will agree to keep it till 30 weeks or 32 weeks gestation. You might go to 28 weeks, you might go to 29 weeks, but I would go against going out of CPAP by 28 weeks, I would say, below 28 weeks. I'd like the comments before we progress into other points of our other colleagues also. What do they think about moving from CPAP to high flow nasal cannula at which gestation?
I think we both agree that they need some form of pressure, but what use, I mean, it depends on the nursing experience in the unit and overall, I mean, have a low threshold to switch back if you think, because de-recruitment is dangerous in these babies, you would end up giving them more than they need before. So careful watching and switching quickly is a key, but I invite Dr. Dua and other colleagues, Dr. Ada, Dr. Dua, do you have any comments?
Thank you, Dr. Fares and Dr. Sridhar. I think also the definition, what's our definition of high flow nasal cannula? Like for example, a flow of 5 liters per minute for a baby who's 1 kilo is different from flow of 5 liters for a baby who's bigger, like 1.5 or 2 kilo. So the different, some people, they define the high flow nasal cannula is around 1.5 to 2 liter per kilo. As per definition. And so for us, as Dr. Sridhar mentioned here, we have found nasal CPAP causes nasal septal injury, and this is the only concern from changing CPAP into high flow nasal cannula. And sometimes we use the interface, the high flow nasal cannula interface, just to prevent the nasal septal injury.
Yes, thank you. You know, we had before, but I'd say in a year time, I might have one nasal injury, maybe in 2, I don't know, but very rare, honestly, those days. You know, nurses become so skillful and they move from nasal prongs to nasal mask every 3 hours. So preventing, and they have a protocol for preventing it. I'm not saying it is not there, it's absolutely there and it happens. Fair enough. So this is any other comment before I progress? Discuss the legal aspect.
No, it's fine.
Yeah. Can I go ahead?
Yeah, please.
So the legal point, I think my problem is with my colleagues who are judging me, not with the legal issue itself, because legally, people will judge you on where the literature, what is the evidence in the literature. The only problem, like I come to judge you, but I don't know well the subject, and I come with my own pre-made idea. So the best way to prevent or treat legal issues is to have more talks about the subjects for people to understand the depth of it. Like myself, when I have my experiences, not so much, it's 1.5 months more than you, because I bought the machines 1.5 months to maybe less ago. So the point is, when I start using it and I found that so many actions that seem totally logic didn't make a difference, then if I am to judge somebody based on the histogram, I will be more reasonable. But if somebody didn't know it and he starts reading 20% DSAT and he says, doctor, 20% of a day is 20% of 24 hours, so many hours of DSAT, and it's your problem, and it's so yes, and it's an issue. So my point is, we need to educate each other on the subject and educate ourselves, and then there will be no legal issue, in my opinion, as long as you didn't do something wrong in the based on literature.
Thank you. Any other questions, Sister Siba, Sam, Dr. Tariq?
The problem is multifactorial, and often we treat it with one thing. So you might have a baby, as you said, distended abdomen, and that's giving him some discomfort. Another baby may be because I did for him a heel prick and he's in pain, or an arterial line or something. There's so many factors and also the associated factors, anemia, hypoperfusion. So we come and treat with one element while many elements are related to, including prematurity, to the outcome.
And one important point we need to stress to the team is the importance of, how you mentioned procedures, for example, how the baby crying more or having the pain might cause them to de-recruit the lung. In a tiny baby, de-recruitment is a very big issue, which can lead to more hypoxia if you keep the same setting. So we shouldn't hesitate to increase the pressure for 1 or 2 hours to recruit the lung and then step back again. That's probably the most important aspect.
You see, that baby whom I presented who had ROP, my treatment is certainly wrong. The patient is clearly straining. He strains so badly that he stops every flow of oxygen to his lung. So myself, I give him oxygen somehow, 23, 25, whatever it is. But if he was open his larynx, he doesn't need my oxygen. I am treating straining by oxygen. At the end, I'm asking why it's not working. Well, it's not working because try to find something to treat his straining if you could.
Yes, and also to identify when you need to increase the pressure rather than the oxygen, because if you increase the pressure, your FiO2 may come down automatically.
Yes.
So I think if there are no other questions, my talk on jaundice, we will keep it another day. Maybe. Yeah, yes, Abu Halwa, sorry.
Yeah, just one question. How does the histogram affect, does it affect your discharge criteria? Like if you have a baby ex-preterm, for example, 25-weeker, now he's 10, he has some fleeting desats, we call it. It's less than 20% of the time. So do you discharge this baby safely?
It's very, very interesting question. We have many, as you have many babies, they reach for home, and now the nurse keep telling you, doctor, he had 5 desaturations yesterday. That's even without the histogram. So at the end, 2 weeks ago, I was doing a part of the unit which is less acute, where there are more discharges. I discharged so many babies who were having desats, but those desats were with feeding. It was very clear. It was a desat only with feeding, and a very minimal desat just very quickly. So deep desat with feeding, I don't want to discharge because you need to monitor. You might give feeding oxygen with feeding. Now, your question is not about that. Your question, what would you do if you have an unfavorable histogram and the patient is ready for discharge and he's not having apnea, he's not having anything, and he's feeding? It didn't happen to me till now, but I would say 5–10% of desaturations is normal when I start approaching, and if those desaturations are in the 88, 87, between 85 and 90, which doesn't hurt anyone, I would tend to let go. But if I see desaturations in the below 85, especially if I have other factors to consider, that every one of you would answer the same as me, I think, dependent of what other conditions the patient have and how he's ready. I would discharge a patient with few desaturations. Yes, it is an issue.
I think I have a solution for that. When we stop the caffeine, you change them to the whole pulse oximeter.
You stop saturation.
You stop calculating the histogram. You just use the whole pulse oximeter. And we are applying the University of Pennsylvania. I don't know if you attended Professor Aikenwald's talk. The University of Pennsylvania recommendations for discharge home, and they're also doing the study of desaturations at home. And you're right. Most babies would continue to have some desaturations, but whether it is significant, so it's more than, if it is less than 80%, more than 10 seconds, or if there is any need to support. So if there is very brief desaturation during feeding, we don't worry.
Yes, babies have periodic breathing, and periodic breathing is by definition associated with desat. All those babies in the postnatal ward who are term baby have some episodic decrease of FiO2. If we put them on histogram and we record it and we act on it, it becomes a problem, yes. But I would be against also saying, I don't want to know. Because the more you know, the more you act better.
Yeah. Thank you. Any other questions? I think it has been an amazing session, and obviously I would like to thank Dr. Fares for his time. I hope you get better soon. And thank you for sparing the time despite having this concern. We would soon catch up on similar sessions. I think it's very informative and interactive as well. And hopefully it will be more useful for everyone joining, and I'll share it as well.
I'd like to be at your session on jaundice, because I also have done a guideline here on hyperbilirubinemia. So it will be good to hear it from you.
Excellent. Thank you. Thank you so much. Thank you everyone for attending.